Okay, so let's move on to chapter 13. If you feel very confident in your CPR and basic BLS training, then this is going to be a great review for you. For those of you who maybe feel less confident or it's been quite a while since you took CPR, this is going to be a good review for you. So, chapter 13 is BLS resuscitation. Keep in mind that cardiac arrest is a basic life support skill. It is non-emergency life-saving care at its base. And additionally, remember that your basic life support training is used to treat airway obstruction. You learned how to treat respiratory arrest and, of course, cardiac arrest. The focus in BLS was always on the ABCs. You know that. Annie, are you okay? Call a code, call 911, open the airway, look, listen, and feel, give 2 breaths, check pulse, start CPR. You don't move past the ABCs. You'll remember that your training taught you that you need to get the AED on within a very short period of time so that your patient has the highest probability of success. Our goal is that our patient doesn't go any more than 4 to 6 minutes without oxygen. It's why we are really pushing emergency medical dispatch and why dispatchers push for the person who's calling 911 to begin CPR. Even if it's hands-only CPR, you'll remember that that is going to help circulate oxygen by creating negative pressure in the chest. We've seen this before. We'll probably see it again. It is a reminder, that time is critical and that the longer you go without oxygen, the greater chance there is of brain death. The body's going to pull the oxygen and stop sending it from the non-essential parts of the body first. But by the time you hit 10 minutes, you are at irreversible brain damage because there's nowhere else to shunt the oxygen from in order to ensure the vital organs such as the brain, the heart, and all have oxygen supply. We know CPR, cardiopulmonary resuscitation. It's what we do to circulate the blood and provide artificial ventilations to our patient. Our goals are to restore circulation through the chest compressions, to open the airway, and to provide breathing, whether it is full artificial ventilation or rescue breathing once they get a pulse back. Isn't that a great picture of a bag valve mask with one man providing both the seal and the squeeze attached to supplemental oxygen, and one person, good straight elbow technique, providing chest compression. BLS is different, obviously, from advanced life support. When we get an ALS provider involved in the code, we've got a patient who then is able to receive cardiac monitoring. They're able to receive intravenous fluids, cardiac drugs, and the use of advanced airway adjuncts such as a supraglottic airway. The system components of CPR are simple. There are 5 chains to good CPR. The first is, of course, that early recognition, and then you move on from there. You don't necessarily need ALS care. If you get them to the hospital in a quick enough amount of time, then they're going to get that advanced life support in the hospital setting. So, just a quick review of that picture. Recognition of the cardiac event and activation of emergency response, immediate high-quality CPR, rapid defibrillation, basic and advanced emergency medical services, and then the advanced life support and post-arrest care. That rapid defibrillation is also why we see a lot of our public access defibrillators. So a lot of your public spaces, airports, coliseums, theaters, sporting centers, they're all going to have public access defibrillation to help with that rapid defibrillation. Just like a good fence, if one of those links is missing, then the fence falls apart. Regardless of who your patient is or how old they are, the basic principles are the same. You might have a difference in the rotation of chest compressions, etc., but for the most part, your process of determining the need and providing the care is going to be the same. The difference between them, though, is that an adult is going to go into cardiac arrest, which is then often going to lead to respiratory arrest. In an infant and a child, what you often find is that the patient is going to go into respiratory arrest. And because of that lack of oxygen, you see an increase in the likelihood of cardiac arrest. Unless your child or infant has an underlying heart condition, they're more likely to suffer from a respiratory arrest first. And that's why for them, it's important if you arrive on scene and they're not breathing, but they still have a pulse, to get that treatment for the respiratory arrest quick so that they don't lead to cardiac arrest. So again, we're going to try to rouse our unresponsive patient, maybe do a shake them, a sternal rub, something to try to get a response out of them. Remember that your AED, your automated external defibrillator, is a link to the process. It is important to get that electric shock to the heart to try to get it restarted. And it's not necessarily that it's restarting it, it's that it's pausing the heart as a reset, telling it, hey man, something's off, this is a hard reboot. And then sending that electrical shock allows the heart to hopefully get back into its normal rhythm. When do we apply the AED? Well, in children, we're going to apply it after the first 5 cycles of CPR. Remember that because of that whole cardiac arrest comes after respiratory arrest in children, you've got to be concerned with the fact that it's really not the heart that's the problem, it's the respiratory system. So you want to get that oxygen moving quickly. We don't do manual defibrillation because we just don't have that process. We do have pediatric size pads that will actually lower the dose of the electronic shock as necessary. So you are going to have special situations that you've got to figure out. Your patient may have a pacemaker, which you'll recognize as kind of a raised area above the heart on the chest, or an implanted defibrillator. The problem is that if these aren't working, then obviously your patient needs something else. So even if they have them, you're going to place your pads appropriately. Just don't place it directly over the pacemaker. If your patient is wet, you want to dry them off as quickly as possible. If you don't know what water and electricity does on a patient who you're trying to save, is not the time to figure that out. And then if your patient has any transdermal medication patches, such as a nitro patch, a nicotine patch, a birth control patch, as long as those aren't in the area where you are placing your AED pads, you should be okay. If they're in the area of the chest, you want to remove the pad and then using a towel or a 4x4 gauze, wipe off any medication that may be left. You cannot effectively perform CPR on a patient who is lying on a soft surface. You need to make sure that your patient is lying on their back on a hard surface. It's why we put patients onto a backboard before putting them on a stretcher. You also need to make sure that your patient is in a place where you have enough room to work. When your patient goes into cardiac arrest on a toilet and falls between the toilet and the tub, you need to move them out of that area if they haven't already done so, which you hope that the dispatcher would provide that instruction before you arrive. After you've checked responsiveness and opened the airway and inserted an oral airway, you're now going to look, listen, and feel for breathing. You're going to look for equal rise and fall of the chest. You're going to give 2 breaths, and then you're going to check pulse at the carotid. And you want to check long enough to make sure that you're certain it's not there, but not so long that you're continuing to deprive your patient of oxygen. We're going to provide quality chest compressions with appropriate hand placement and good depth. This means running our fingers up the rib cage and placing the heel of our hand 2 fingers above the xiphoid process, remembering to go at the appropriate rhythm of 100 beats per minute not faster, not slower, and the appropriate depth, at least 2 inches in your adult patient. It is important to ensure that you allow the chest to relax. So you come up and release pressure. Not necessarily moving your hands, but not putting any pressure on the chest so that your patient's heart can fill appropriately before you compress again and push the blood through. And again, here's just a picture of where the heart lies within the chest and where the lungs are. Remember, when you're doing compressions, your shoulders should be square over the patient. You should not have an angle because then you're not pushing down directly on the sternum the way you need to in quality CPR. And here's just a picture, a reminder, which you should have already done this, so they probably should have put this before we talked about compressions. Head tilt, chin lift in the first picture and the jaw thrust in the second. Remember, head tilt, chin lift in your semi-conscious and non-traumatic. Hopefully, if your patient is semi-conscious, you're not doing CPR. And your jaw thrust in your trauma patients, or if you can't be certain they're non-traumatic. If the patient is breathing, if the patient has no injuries, just maintain the airway, place the patient in the recovery position. Remember, that's them on their side. And suction the airway as needed. If they have no spinal injuries, then you probably don't need a backboard, but you do want to transport them and maintain that airway. Here's a picture of the recovery position. This way, if while you're getting equipment or getting the history from somebody, they happen to vomit, it's not going to go right back into their airway. You need to remember that appropriate ventilations are key. So when your patient is not breathing, ventilations need to be done at the appropriate depth, allowing for the amount of air that they would normally take in their regular respirations to be put into their lungs. Use a barrier device if you're doing mouth to mouth. We prefer mouth to mask, but obviously our top preference is 2-man bag valve mask with supplemental oxygen. So this is just a picture of 1-man bagging of your patient using the EC method with the appropriate seal and squeezing the bag appropriately. You may have a patient who has a stoma. So if your patient has a stoma, and we've talked about this under the airway lecture, you are going to need to bag from the stoma, because if you bag from the nose and the mouth, then the only place you're going to feel the air movement is out the stoma. You've got to be cautious though, because you can cause gastric distension, so air into the stomach. And you've got to remember to have your suction unit ready, because anytime we're dealing with the airway or putting air into the airway using a bag valve mask, you do increase the chance of your patient vomiting. And this is just a picture of bagging at the stoma. So you see in that first picture, your patient has the surgical airway opening. And in the second picture, they're using the neonate mask, so an infant mask, to create a seal. The adult mask obviously wouldn't fit appropriately. And then they are going to bag the patient, same rate, same rhythm, same depth of squeeze, but just from a different location.